And I know you have, and I know you have a slide deck that it looks like you can now share. You want to take it away? Thank you.
Yep, absolutely. So thank you so much for the invitation. I'm here today on behalf of the Gravity Project. I've been working with the Gravity Project since its inception to standardize social determinants of health data for both for collection, but also for use and exchange across the diverse systems in the national ecosystem. So not just clinical settings, but patients, community-based organizations across the board. To try to advance that work, as Timmy said, I also have some other hats. So last year I was on the US CDI task force that recommended the addition of the SDOH data elements to US CDI version 2. And this year I sit on the Interoperability Standards work group, which is considering US CDI version 3. And I sit on a variety of other working groups to try to make all of this happen. Timmy's asked me to give you a very fast overview of the Gravity project in order to leave some time for questions. So it may feel a little bit like a roller coaster, but I want to leave time for your questions. There's a lot more behind this. So starting point, the big picture for us and for the nation, 20% of one's health status is explained by factors in the healthcare setting. 80, perhaps 90% of one's health status is explained by factors outside the healthcare setting. So tracking the data, collecting it, using it becomes very important for achieving better care, better health equity, better value. So this Gravity project started in 2018, and our primary goal is to develop data standards to represent and exchange patient-level data documented across 4 clinical activities, clinical so far: screening, assessment, goals, and interventions. Impact in that means we're both working on the content of the domains that you see on the right, like food insecurity, housing instability, transportation insecurity, but we're also working on the FHIR exchange standard that helps send it in a common form from one entity to another, or for those who do not have a FHIR server, to use a FHIR API, an application programming interface, so that a community-based organization could send some data to, for example, a clinical setting. So in that project scope is both the terminology side, the content side, but also the exchange side, because we are an HL7 FHIR accelerator. Once we do that, we are also trying to test and validate the standardized SDOH data for a variety of use cases: patient care, care coordination between health and human service sectors, population health management, public health, value-based payment, clinical research, and others. And I'll get into a little bit of very fast detail on that. There is a lot of complexity packed into this one single slide. This is what allows me to go quickly. So this is our process. We start by picking a domain, say food insecurity, and we bring together subject matter experts on food insecurity, and not just your traditional subject matter experts. We make sure we bring people from the community, people who are working with patients on the issues, as well as people who are might be in clinical care or public health. We think about the range of people who need to be around the table in order to look at a domain, to identify what are the proper things to track, what are the proper value sets. We do that again across across the common activities: screening, diagnosis, goal setting, interventions. We use the common value sets. We're thinking of them all: LOINC, SNOMED, CT, ICD-10, CPT. We go through this iterative process with the subject matter experts, also with our public collaborative, which is over 2,000 people across all stakeholder segments nationwide. We present on these domains in public calls. People ask questions, they raise points of clarity, they actually spot things that we didn't think about, even with our subject matter experts. It's a dynamic, collaborative process. It's all for the greater good. When we get a consensus vote from that public collaborative, meaning more than 2/3 say yes, it's ready to go, at that point, the Gravity Project submits the value set for that particular domain, like food insecurity, to the coding steward. So it might be LOINC, it might be SNOMED CT, it might be the ICD-10 committee. And they decide whether to approve it and whether to publish it. So another sort of vetting process happens there. Then we're also working side by side on those content standards with the exchange standards. So as I said, we're an HL7 Fire Accelerator. We have an SDOH clinical care implementation guide that has been balloted and published. We are working on the STU 2, the second version of that. In that process, we both develop the implementation guide, we test it in connectathons and pilots, we ballot and we publish it according to the HL7 process. While it's a clinical care guide at the moment, we do envision other use cases and implementation guides, such as social care, quality measurement, public health, research, and so forth, and I'll get into a little more detail. Lastly, because we have an end-to-end design in mind, so it's not just clinical care to clinical care, we have developed a reference implementation that allows that the communities can use, community-based organizations, the referral platforms, even patients can use in order to design exchange with clinical settings using smartphone and web apps connecting to FHIR application programming interfaces. There's a lot behind that, but that's a quick summary. This is a graphic illustration of the work streams together. So the terminology work stream working on designing and identifying the codes, working side by side with the technical work stream at HL7 FHIR on how to exchange those with a common standard across national use cases, and then piloting that with testing and implementation on the bottom. What this does collectively, it allows us to take the content working through the exchange standards and reach out to all the different stakeholder uses and use cases that you see there on the right. So definitely regulators are using this. I'll get into the USCDI shortly. EHR vendors can use it, payers, patients, clinicians, registries, and researchers. The public collaboration. This is a really important piece of the Gravity project. It's something that I think that a lot of the different stakeholder segments value, is that we have brought together people together in an open and collaborative process. All of those stakeholder groups are represented. In fact, our governance standards require representation of all the different stakeholder groups around the table. Those are minimums. We actually work to do even better than that. But you can see we're thinking holistically about all of the people who are using this system, because this is designed to serve across the national ecosystem. Quick roadmap of what 2021 looks like, and I have one coming for 2022. There's a lot in play. So on the top, terminology, all of those, we stack those content standards in different ways depending on who the experts are that we can bring together. Sometimes you build on one previous domain, so we stack that way. All of this has to line up. You see that line in the middle about when the coding stewards are making decisions, when they require submissions. We have to make sure that our work lines up with their requirements for when they receive our coding submissions so that it can then get published and used by the public. We also have then on technical, we have the FHIR IG balloting process at HL7. Those are specific timelines, the reference implementation timelines, and then the piloting. So all of this, it's a multi-layered parallel process trying to get as much done as possible, as quickly as possible to meet the national need. This is the 2022 roadmap.
Hey, Mark.
A little saner. Yes.
Can you go back? Just have a question about the slide. You have in January the different colors and domain areas, yes. And then so if I look at inadequate housing, then I see social connection on the right. Is there any tie, or how should I be looking at these colors versus?
Good question. Those are carryovers from the previous year.
Okay.
So we wanted them on the same slide so that people didn't forget that that we hadn't forgotten. But they were there just as carryovers, and this will allow me to say one thing, that in those code sets, There are separate code sets for assessments, for interventions, for goals, for diagnoses. We don't necessarily do all 4 sets of code sets for inadequate housing at the same time. Even there, we had to sometimes stack them up. So I'm just making this up. But in January, we may have had code sets for assessments for inadequate housing, but not yet have had code sets for interventions for inadequate housing. So we might have been continuing to do some work in 2021 because not everything was done on inadequate housing. So there's that level of stacking too. But that's, to answer your precise question, that's why they're all lined up there neatly in January.
Great, great, thank you.
Okay. So as I was saying, little saner, because we got so much done in 2021, we are trying to slow down just a bit because this is a marathon. And we are picking up in 2022 with personal health literacy, underinsurance, and medical cost burden as our 3 domains at the beginning of 2022. And then we are working on what the domains are going to be in the second half of 2022. A teaser from a slide to come, we are beginning to look at racism, discrimination, and bias as a domain. And I'll have a little more to say about that. On the technical side, we are balloting STU2, and I'll have a slide that shows a little bit more about what that means, and then again, the pilots. So on STU2, this is a data map to show who's being connected. So you often think of clinical payer systems connecting. Those are the entities that probably have FHIR servers, and the STU1, the first version, connected those with the blue lines. But in our end-to-end vision, we need to have the community-based organizations, the coordination platforms, the patients also connected. So those are the orange lines. They often don't have FHIR servers. They may not even be using really FHIR in their work. We need to take that into account. So there we are working on the reference implementation that can be used for smartphone and web apps to make sure that we actually have a form of connection for capture, exchange, and use across all of the important stakeholder groups in the ecosystem. So to how we're moving this into action, and this is really about the policy side. Last year, when I was sitting on the USCDI task force, we did recommend to the Health IT Advisory Committee that they include the SDOH data elements the Gravity Project submitted. The task force agreed, HITAC agreed, made that recommendation to the national coordinator, and July 2021, the national coordinator released a final version of USCDI version 2 that does include the Gravity Project's SDOH data elements. And that's a huge thank you to the entire Gravity Collaborative that really made this possible at such a quality level. More work to be done. I've already described some of it: implementing it, piloting, testing, iterating. So STU2 is an iteration of STU1. Learning from how the content of the code sets are being used in the community may show us that we need to reframe something or we need to tweak something. So always thinking about learning from the community about what has happened. Here in a nutshell is what is in USCDI version 2. All the black font is USCDI version 2. So they added those 4 elements there. Those 4 elements include each of the domains listed under the 3rd column for domains, all of the code systems and value sets on the right column for those particular activities. So not all code sets cover all activities. So that's why you see the bullets about like LOINC, justice for assessments, goals, and outcome measures. And then again, all using the SDOH clinical care implementation guide for exchange. But here's what our next steps are. So we are working on health literacy, healthcare access, underinsurance, medical cost burden, and beyond mid-2022, we're looking at not only racism, discrimination, and bias, but also some neighborhood elements, food access, neighborhood safety, green space. We know racism and discrimination are top of mind. We also know that there's a lot to unpack there, and we want to be careful. So unlike some of our domains, which may be accomplished within a quarter or within a half a year, we are expecting that the work on racism will take longer than that. but we're starting now. We also will not be surprised if, as in the past, that gets broken up into different pieces. So it could be, so I'll give you an example. We started off with interpersonal violence. We quickly realized that it really needed to be broke up into intimate partner violence and elder abuse, and also child abuse, which is a separate domain that we have not taken on yet. That kind of thing happens. So we're just naming the big overarching category here in the plans to begin to work. The more use cases, so clinical care, quality measurement, population health, public health, directory exchange, and then more activities and data elements, some of which are already in the works: data aggregation, billing, health insurance, outcomes consent. All of this will serve a variety of use cases that use US CDI. So it's not just some of the typical things, but definitely health equity, definitely value-based care, interoperability, COVID-19, all, these kinds of data elements. We know from what's been happening for the past 2 years that if we had had this kind of data in on SDOH, it would have been a lot easier to do some of the interventions around treating for COVID-19. So a reminder that that this work actually serves a variety of use cases that are important in California, important nationwide. Here are links to join the work of the Gravity Project if that interests you. All are worthy, all are welcome. It really helps and makes a difference. And with that roller coaster, I'm all yours for questions and discussion.
That was fantastic. Definitely a fountain that we are drinking, but I'm going to start off with a couple of questions. So can you put this in context of data collection? So I immediately go to, this is awesome, but how do we make sure that our providers, in a clinic setting on said EHR has the capability to start collecting this data now? And what is that time lag, or what can we do to make sure that they know that their EHR provider should have the capability to be able to allow them to collect this data?
Okay, so I think I heard actually two pieces in your question. You started off asking about how it's being collected, and then you talked about capability. So that's the age-old, under the Meaningful Use program, that's the age-old separation between capability and use. And just because it was built into EHRs, the capability, and that was sort of under ONC's jurisdiction, didn't mean that regulators were requiring providers to use it.
Right.
So we had some great things that could be done, but that actually weren't being put into place. What the Gravity Project has done is to try to do as much as we could to create that capability, but we don't require use. So we can make it available. We can actually think out of the box and make sure that that the capability and the possibility of use is even available in the community by community-based organizations, referral platforms, and so forth. But once there, it does have to be used. So I think we're looking at the hat that I wear as somebody sitting in policy circles. I do raise that issue that it's important to consider. The federal agencies are integrating the Gravity Project standards. So CMS issued a letter to state Medicaid officials saying you should really be looking at the Gravity Project standards. CMMI said it was going to start requiring SDOH assessments in its payment models. So these are, and White House Office of Science and Technology Policy just issued an RFI, request for information, asking how can we strengthen community health using health technologies. And our answer is the Gravity Project is a pretty successful national model, and the more you integrate it and require its use, the faster we can move. So, to summarize, yes to capability, but also yes to use, and we see that beginning to happen. It needs to happen more.
Thank you.
And since this group is very aware of what's happening with the data exchange framework, I am pleased to observe that California is thinking ahead of the curve on that. and has asked the advisory group to talk about how SDOH data can be integrated and exchanged and used. So something I'm also working on. I'm a member of the stakeholder advisory group as well. Haven't been wearing that hat on this presentation, but definitely carrying the water in that venue.
And we will definitely support you there. On that same note, there's a question in the chat that is, how does a CBO get their paper record or case management system onto a mobile app?
So you can, it may be a paper records. I mean, CDAs are about exchanging paper records or documents as well. So you can do that with FHIR. It's not optimal, but what we're doing does meet people where they are, and it can be done. For better care, optimally we will be working towards a system where we're working with structured data, and so you can combine things and analyze things in a more efficient way. But that should still be a possibility as different people are working at different speeds to move forward.
Thank you. And
I'm sorry, I haven't been tracking the chat.
No, I'll do that for you. Another question, and I have one in the same area, is could you please describe if and how tribal nations have been involved?
I have not looked at they're definitely equally in mind, along with all the other underserved and marginalized communities that are so frequently overlooked. I have not looked at a breakdown of participation. I'm aware that our outreach, as a general matter, reaches out to everybody, and even in the current work with the stakeholder advisory group, I reached out to CRIB, California Rural Indian Health Board, to make sure that they were aware of what we were doing. So just an example of it, but I don't actually have. I haven't looked at a specific breakdown, so I don't have a specific answer to that, other than to say, yes, it's critical, and yes, we're doing it.
And I have a follow-up question there with the youth lens. And you said that you haven't tackled child abuse yet, but do all of the different domains carry a youth side? What kind of particular information needs to be pulled through to be able to support youth?
So I'm not looking at the chat. Is that youth, Y-O-U-T-H, or youth?
Yeah,
USC?
youth. Yeah, Y-O-U-T-H. Kids.
Okay. So I think it depends. We will always start with what our subject matter experts tell us. If they think that things can effectively, efficiently be looked at with a lens that doesn't differentiate by age, then just speaking generally, we would probably do things that way. And then we might, at the individual code value sets, we might make some distinctions within particular answers that might vary by age. But if our subject matter experts say, as they did here, there are some significant differences, and we really need to build this separately. So, reproductive health may be another example. We would pick up on their learning and do that. And I should say, as I did before, it's not necessarily just what the subject matter experts say. We start there because we want to make best use of our public collaboratives time. So we want to try to get a good draft going. But if somebody in the public collaborative raised that as an issue, and we thought about it, because we always answer their comments, and we thought about it, and realized that really needed some further look, we would actually go back and look at that as well before we moved forward. Does that answer the question?
It does. Thank you. I just think there's so much emphasis on mental health for our youth, and being able to make sure that we're getting a real picture of how to help is so.
Yeah.
The question, and I don't want to divert the topic too much, but how is abuse, child abuse, elder abuse, whatever, how is that recorded? Because typically a provider just reports a suspicion or a suspicious injury, and then there has to be a law enforcement investigation. How is that captured? I'm kind of curious, but I don't want to divert too much if it's too lengthy.
Well, unfortunately, the quick answer may be I'm not an expert in that area, and I have not delved into that particular domain. But I would say in our general approach is to start with assessment questionnaires. So I think we actually back up from the scenario that you're talking about and actually capture some information before we have to get to the questions that you're talking about.
Oh, okay, that's fine.
And we can follow up with you, Mark, on that. And Jim,
Great.
I see your hand raised.
Oh, I do, thank you. And I just want to mention, is my camera working? I guess my camera isn't working. Okay, so I'm sitting in the dark. There we go. And Mark, I know Evelyn and I know Linnell, and I fully support the work of Gravity, but I think for the context of this audience, especially Lois's question, it's kind of important to point out that Gravity as a fire IG is again about clinical information exchange for clinical value. And you know, whether or not a particular CBO has a fire server or not, nonetheless, those CBOs then connect into their own workflows. And so like Lois's example, you know, that's a workflow that involves a child welfare agency, perhaps a housing agency, perhaps law enforcement, which all have their own dissimilar standards and information exchanges. So it's very valuable to consider Gravity in the context of how you move this information and inculcate it into clinical workflows. But I don't want to see it, or I hope it's not suggested to oversimplify that all of those other workflows, especially where the CBO is a conduit, don't have other data challenges for integration in a more holistic aspect to get that information for a patient.
Agreed. And that's why we're mindful of the other use cases and implementation guides on the left column as well that don't guarantee that everybody is integrated, but may help move the various systems to a more common standard along with clinical care.
I have 2 more questions and I think we can move on. Reed?
Yeah. Hi, Mark. Reed Holman with Unite Us here. Appreciate you being here. I have 2 questions. One is actually following up on this previous discussion about more on the use side of things, but let me throw them both out and then you can react. One, in the world of standards development, Gravity Project is one entity, and there are various out there. I wonder if you can kind of paint that ecosystem a little bit. I know that Gravity Project is, particularly being within HL7, is, if you will, the center of gravity, you know, for a lot of those conversations. But I wonder if you can just paint.
I've never heard that before.
Second question, you know, and as from the healthcare lens, as healthcare moves into the community, I don't like that framing, but I think you know what I mean when I say that. Obviously, lots of organizations that have long been funding and systems have been within the community. CBOs have been mentioned here. There are others like, you know, a prominent example would be HUD-funded HMIS systems. You know, there are substance use focused systems like Avatar as a vendor, you know, that has long been in this space. And I'm just wondering, is there standards development like on that side of the equation? How do those types of systems, you know, when we think about standards adoption that is moving into a place where really people have been for some time, can you just speak to like the integrations or the conversations with those types of groups? If that, yeah, I think you're nodding, so hopefully that question makes sense.
I can, and Timmy, you'll just tell me when I run out of time. So your question about we're one entity. I think it was written on a slide, but I failed to lift it up orally. We try to be agnostic about the major screening tools that are used, the code sets that are used. We're trying to build for the large common ones that are used across the ecosystem. So we're not trying to dictate or drive anything. We're trying to be open and as open and inclusive as we can, and our implementation guide is designed that way as well. So all of these code sets and value sets that you see on the right are there. It's not everything in the United States or the world that's being used, but it covers a lot of territory, and that's our value is to try to serve the variety, the various systems that are in play. Hopefully that answers your first question. To your second one, yes, there are different systems in place. All of those agencies, for example, like HUD, are invited to come to the Gravity Project's work. Many of them do come. We have some pretty close connections with CDC, CMS, with NIH. We've worked, HUD has some screening tools that are pretty helpful in the housing area. We've reached out to them. They have people who sit on our subject matter domains in that area. So there are ways that are broad and ways that are deep in which we are making connections with the Gravity Project's standards. Some of them may yield fruit immediately, like already. Some of them may yield fruit in a year to 2 years. I note one of the things that is behind the recommendations from the US CDI task force last year led to about thinking about how these data elements are actually building blocks for a variety of use cases, caused federal agencies to start collaborating under what's called US CDI Plus. So it's different from it's a little different from US CDI, but US CDI Plus to identify common data elements that serve their needs in all of their respective jurisdictions so that they really can focus on getting those built collectively across the agency. So you can fast forward a year or two and imagine that those diverse systems that you were describing start to come together and at least to integrate better with Gravity Project standards around social determinants of health. So that's the strategy, that's the vision, that's the goal. We're trying to make it so.
Yeah, that makes sense. Even like philosophically, it's like the standards development process is really a byproduct of the relationships and the folks that are in the room. So how do we get the right folks in the room? Yeah.
And I'm going to pull that back that, it's something that we can do too, is to make sure that we're pushing our partners, especially those that we're working with at community and county level, that crossover into public health and county, to be able to adopt these as well. Robbie, you want to one more question?
Yeah, I'm just curious back to the capability and use piece. Are there, and that's relation to what California is undertaking with the data exchange framework. Are there states that have, in your mind, on the capability side, helped push for, these different data elements in various states, whether through, Medicaid programs or otherwise? And then same with, enabling use at the state level too. Are there any states that maybe are doing this work and helping push this coding forward as well?
Yeah. So there's a couple of layers to that. Let me first say, patients and communities have been living with this the reality of these domains in front of you for centuries, millennia. So the answer is yes. Across the states, people have been living with this all their lives. We're really talking about sort of at the more institutional and governmental level. This work of standardization is fairly fresh. There have been lots of efforts that were going on before US CDI V2 incorporated the SDOH data elements. But they also started to look different. They weren't necessarily the kinds of things where maybe they were in paper form, so you couldn't actually do some of the things you could with structured data. All the traveling that goes back and forth, you might not be able to cross state lines or system lines with some of that, even from a primary care physician to a specialist, or from a primary care physician to a service provider like a food bank. That work is recent, and I think we are actually trying to build rollout as we speak. It's a little early to know who's doing what. ONC and CMS have built Gravity standards into some of their grant programs already. I don't have the short list top of mind at the moment, but we are starting to I think we're starting to see that at a state level.
Thank you. And I see, Stephen, you have your hand up. Was wondering, I want to get on to our meeting, but is it a quick one? If not, we can put it into the email or into the chat.
That's fine. We can wait.
Okay, great. So Mark, thank you so much. And if you have additional questions for Mark, maybe you can stay on. There's another couple questions that came in on the chat, if you wouldn't mind taking a look at those.
Okay.
And answer them
So I
there.
will stop sharing, free the screen up, and I'll move to the chat. Thank you so much for the invitation.
Thank you, Mark. And you will send out can you remind us again on your meetings? It's on Thursdays?
The public collaborative meetings are on Thursday, yes.
And that would be,
So
you would recommend
that's in
that's
the
where
slide
folks
deck.
start to get engaged?
Yeah, that's a great place. You'll get sort of a comprehensive view of where we are at a particular moment. So by that, I mean, the next one will probably have a lot of focus on health literacy because that's the domain we have in place, but it will still cover the snapshot of what's been covered before and what else might be coming.
Terrific. And if anybody has any additional questions or follow-up, do we point them to you, or is there someone, or you might be able to put in the chat?
Point them to me, and I can make sure that the question gets answered.
Okay, and then we are here if there are some areas, of course, in the data exchange framework or where California is going, let us know how we can support there.
Thank you. Well, you're going to model it for the nation, right?
Sometimes that's the position we get ourselves in California.
I have lots of hope.
Okay, sounds good. All right, thank you again. I'm going to go back to our regular programming and point everybody to the draft letter. Any questions or comments there? I don't think we received very many.